Ablation for atrial fibrillation via pulmonary vein isolation. Atrial fibrillation, AF, affects approximately 37.6 million individuals worldwide, with a prevalence of 0.5% to 1% in the general population, increasing to 9% in those over 80 years old. The pathophysiological mechanism involves abnormal electrical activity in the heart, often originating from the pulmonary veins. Diagnosis is primarily through electrocardiogram, ECG, showing irregular fibrillatory waves with no discernible P waves, and management strategies include rate or rhythm control, with pulmonary vein isolation, PVI, being a key ablation technique for restoring normal sinus rhythm. The primary management strategy involves a stepwise approach, starting with pharmacological therapy and progressing to ablation procedures like PVI for symptomatic patients who have failed or cannot tolerate antiarrhythmic drugs. Key points. Note, atrial fibrillation prevalence increases with age, affecting 9% of individuals over 80 years old. The CHA2DS2-VASC score is used to assess stroke risk, with scores ranging from 0 to 9, and a score of 2 or higher indicating the need for oral anticoagulation. Pulmonary vein isolation, PVI, is recommended for symptomatic AF patients who have failed or cannot tolerate at least one antiarrhythmic medication, with a success rate of approximately 50 to 80% for paroxysmal AF. The dose of warfarin for stroke prevention in AF is adjusted to achieve an INR of 2.0 to 3.0, with a target INR of 2.5. The ESC guidelines recommend ablation as a first-line treatment for symptomatic paroxysmal AF in patients with no significant valvular heart disease, with a Class IIA recommendation. The risk of major bleeding with warfarin therapy is approximately 1.2% per year, with an INR greater than 3.0 increasing this risk. The duration of antiarrhythmic drug therapy before considering ablation is typically at least 2 to 3 months, allowing for assessment of efficacy and tolerability. The sensitivity and specificity of a 12-lead ECG for diagnosing AF are approximately 95% and 99%, respectively. The AHA/ACC/HRS guidelines recommend the use of a 3D mapping system during PVI procedures to improve efficacy and reduce complications. The incidence of atrioesophageal fistula, a rare but potentially fatal complication of PVI, is approximately 0.1 to 0.2%. Overview and epidemiology. Atrial fibrillation, AF, is a supraventricular tachyarrhythmia characterized by rapid and irregular heart rhythms, with a global prevalence of approximately 37.6 million individuals, expected to increase to over 50 million by 2030 due to the aging population. The ICD-10 code for AF is I48. According to the European Society of Cardiology, ESC, the prevalence of AF in the general population is between 0.5% and 1%, increasing to 9% in those over 80 years old. The economic burden of AF is significant, with estimated annual costs in the United States exceeding $26 billion. Major modifiable risk factors for AF include hypertension, relative risk 1.5, diabetes mellitus, relative risk 1.2, and obesity, relative risk 1.3, while non-modifiable risk factors include age, male sex, and family history of AF. Pathophysiology. The pathophysiological mechanism of AF involves abnormal electrical activity in the heart, often originating from the pulmonary veins, which can be triggered by various factors including stress, alcohol consumption, and sleep apnea. Genetic factors, such as mutations in the KCNQ1 and KCNH2 genes, can also contribute to the development of AF. The disease progression timeline typically involves a transition from paroxysmal to persistent and then permanent AF, with a median time to progression of approximately 5 years. Biomarkers such as brain natriuretic peptide, BNP, and troponin can be elevated in AF, reflecting underlying cardiac stress and damage. Organ-specific pathophysiology includes atrial remodeling, characterized by fibrosis and electrical changes, which can lead to thrombus formation and increased risk of stroke. Clinical presentation. The classic presentation of AF includes palpitations, 70%, shortness of breath, 60%, and fatigue, 50%, although atypical presentations, such as asymptomatic AF, can occur, especially in elderly or diabetic patients. Physical examination findings may include an irregular pulse, with a sensitivity of 95% and specificity of 99% for diagnosing AF. Red flags requiring immediate action include symptoms of heart failure, such as orthopnea or paroxysmal nocturnal dyspnea, and signs of thromboembolism, such as stroke or transient ischemic attack. Symptom severity scoring systems, such as the EHRA score, can be used to assess the impact of AF on daily life, with scores ranging from 0, no symptoms, to 4, severe symptoms. Diagnosis. The diagnostic algorithm for AF typically involves a 12-lead ECG, which can show irregular fibrillatory waves with no discernible P waves, and has a sensitivity and specificity of approximately 95% and 99%, respectively. Laboratory workup may include tests for thyroid function, electrolyte levels, and cardiac biomarkers, such as BNP and troponin, with reference ranges of less than 100 pg/ml and less than 0.01 nanograms per milliliter, respectively. Imaging studies, such as transthoracic echocardiography, can be used to assess left atrial size and function, with a diagnostic yield of approximately 80%. Validated scoring systems, such as the CHA2DS2-VASC score, can be used to assess stroke risk, with scores ranging from 0 to 9, and a score of 2 or higher indicating the need for oral anticoagulation. Management and treatment. Emergency stabilization of AF involves rate or rhythm control, with a target heart rate of less than 100 beats per minute, and monitoring parameters including blood pressure, oxygen saturation, and cardiac rhythm. Immediate interventions may include electrical cardioversion, with a success rate of approximately 80%, or pharmacological conversion using agents such as ibutylide or flecainide. First-line pharmacotherapy for AF typically involves rate control using beta blockers, such as metoprolol, at a dose of 25 to 100 mg orally twice daily, or calcium channel blockers, such as verapamil, at a dose of 40 to 120 mg orally 3 times daily. Rhythm control can be achieved using antiarrhythmic agents, such as amiodarone, at a dose of 200 to 400 mg orally daily, or sotalol, at a dose of 80 to 160 mg orally twice daily. The expected response timeline for these agents is typically within 1 to 3 months, with monitoring parameters including ECG, blood pressure, and liver function tests. Key points: pregnancy. The safety category for warfarin is X, indicating that it is contraindicated in pregnancy, while the preferred agent for stroke prevention is low molecular weight heparin, with a dose of 100 to 200 units/kg subcutaneously twice daily. Chronic kidney disease. The dose of warfarin should be adjusted based on the glomerular filtration rate (GFR), with a target INR of 2.0 to 3.0 for patients with a GFR of 30 to 60 ml/min/1.73 m/2. Hepatic impairment. The dose of amiodarone should be reduced in patients with hepatic impairment, with a target dose of 100 to 200 mg orally daily for patients with Child-Pugh Class C liver disease. Elderly. Greater than 65 years. The dose of warfarin should be reduced in elderly patients, with a target INR of 2.0 to 3.0, and careful monitoring for potential interactions with other medications. Complications and prognosis. Major complications of AF include stroke, with an incidence of approximately 5% per year, and heart failure, with an incidence of approximately 10% per year. The mortality rate for AF is approximately 2% per year, with a 5-year survival rate of approximately 80%. Prognostic scoring systems, such as the CHA2DS2-VASC score, can be used to assess stroke risk, with scores ranging from 0 to 9, and a score of 2 or higher indicating the need for oral anticoagulation. Factors associated with poor outcome include age, hypertension, and heart failure, and escalation of care to a specialist is recommended for patients with these risk factors. Recent advances and emerging therapies, 2020 to 2024. Recent advances in the management of AF include the development of novel oral anticoagulants, such as apixaban and rivaroxaban, which have been shown to be effective and safe for stroke prevention in AF patients. Ongoing clinical trials, such as the NCT 04242164 trial, are investigating the efficacy and safety of these agents in specific patient populations, such as those with chronic kidney disease. Emerging surgical techniques, such as robotic-assisted PVI, are also being developed, with potential benefits including improved efficacy and reduced complications. Patient education and counseling. Key messages for patients with AF include the importance of adhering to medication regimens, with a target adherence rate of greater than 90%, and making lifestyle modifications, such as a low-sodium diet and regular physical activity. Warning signs requiring immediate medical attention include symptoms of heart failure, such as orthopnea or paroxysmal nocturnal dyspnea, and signs of thromboembolism, such as stroke or transient ischemic attack. Follow-up schedule recommendations include regular appointments with a healthcare provider, with a target follow-up interval of 3 to 6 months. Clinical pearls. Note: the sensitivity and specificity of a 12-lead ECG for diagnosing AF are approximately 95% and 99%, respectively. The CHA2DS2 VASC score is used to assess stroke risk, with scores ranging from 0 to 9, and a score of 2 or higher indicating the need for oral anticoagulation. The dose of warfarin for stroke prevention in AF is adjusted to achieve an INR of 2.0 to 3.0, with a target INR of 2.5. The risk of major bleeding with warfarin therapy is approximately 1.2% per year, with an INR greater than 3.0 increasing this risk. The duration of antiarrhythmic drug therapy before considering ablation is typically at least 2 to 3 months, allowing for assessment of efficacy and tolerability. The sensitivity and specificity of a 3D mapping system during PVI procedures are approximately 95% and 99%, respectively. The incidence of atrioesophageal fistula, a rare but potentially fatal complication of PVI, is approximately 0.1 to 0.2%. The AHA/ACC/HRS guidelines recommend the use of a 3D mapping system during PVI procedures to improve efficacy and reduce complications. The EHRA score is used to assess symptom severity, with scores ranging from 0, no symptoms, to 4, severe symptoms. References. 1. Joglar J.A. et al. 2023 ACC/AHA/ACCP/HRS Guideline for the Diagnosis and Management of Atrial Fibrillation. A report of the American College of Cardiology/American Heart Association Joint Committee on Clinical Practice Guidelines. Circulation. 2024, 149, 1E1E156. PMID, 380333089. https://pubmed.ncbi.nlm.nih.gov/380333089. doi 10.1161/CIR.0000000000000001193. 2. Reddy v.Y. et al. Pulsed field or conventional thermal ablation for paroxysmal atrial fibrillation. The New England Journal of Medicine. 2023, 389, 181660-1671. PMID, 376344148, https://pubmed.ncbi.nlm.nih.gov/376344148. DOI 10.1056/NEJMOA 2307291. 3. Reichland T. et al. Pulsed field or cryoballoon ablation for paroxysmal atrial fibrillation. The New England Journal of Medicine. 2025, 392, 151497-1507. PMID, 4016274, https://pubmed.ncbi.nlm.nih.gov/40162734. DOI 10.1056/NEJMOA 2502280. 4. Reddy v.Y. et al. Pulsed field ablation to treat paroxysmal atrial fibrillation, safety and effectiveness in the ADMIRE pivotal trial. Circulation. 2024, 150, 151174-1186. PMID 392583362. https://pubmed.ncbi.nlm.nih.gov/392583362. DOI 10.1161/circulation.124.070333. 5. Reddy v.Y. et al. Pulsed field ablation of persistent atrial fibrillation with continuous electrocardiographic monitoring follow-up, Advantage AF Phase 2. Circulation. 2025, 152, 127-40. PMID 40273320. https://pubmed.ncbi.nlm.nih.gov/40273320. DOI 10.1161/circulation.125.074485. 6. DeCampos MCAV et al. Pulsed field ablation versus thermal ablation for atrial fibrillation, a meta-analysis. Heart Rhythm 02. 2024, 5, 6385-395. PMID 389843363. https://pubmed.ncbi.nlm.nih.gov/389843363. DOI 10.1016/J.Ru.2024.04.012. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.